This is the Fix Your Sciatica podcast. So let's talk about the black box of physical therapy and also just understanding what to expect when you are working with a provider. And today's guest is an extremely special guest because I've been following him since 2014, 2015 throughout my education. It got me turned on to the information and knowledge that he brought to the table. And he actually teaches other clinicians on his current treatment methodologies. And he's the founder of Modern Manual Therapy, which he'll probably tell you a little bit more about. So today I have Dr. Urson Religioso the third, Religioso the third, or Dr. E. Dr. E, good to see you.
Hey, great to finally meet you, Ashley.
Yeah, it's been a long time coming. I know that we've been following each other, or I've been following you for a long time, and it was great the fact that we got connected and you were down to take the time out of your busy day to answer some of these big questions. Now, I'm a huge fan. Some of the listeners may or may not have come across your name throughout their podcast or internet journey. Tell us a little bit more about yourself and what you do.
Well, I'm a doctor of physical therapy. I may even have been one of the first doctor of physical therapies in New York State. I mean, I graduated with a BS and MS in PT back when the MS was controversial. That was way back in 1998. So I've been doing this 26 years. And then I really I loved manual therapy. I had this amazing ortho professor. I don't know if you've ever heard of him being around the New York area, Dr. Ron Shank. He was one of the first big cert MDTs who became a manual therapy fellow. And since he was my ortho professor, back then, orthopedics just had 3 credits, 1 semester, 3 credits. We had 2 5-credit semesters. That was unheard of. That's standard now, maybe even a little low. I don't even know what's standard now. But back then, having 1 semester devoted to manual therapy of the extremities and 1 semester manual therapy and orthopedics of the spine. So he was really big into spinal manipulation, but also combining that with the active strategies that McKenzie promoted, because he was, again, McKenzie first and foremost, and then he became manual therapy fellow. So that really inspired me to want to become a chiropractor, because I just thought that spinal manipulation was the end all be all. And I ran up at my parents the last year of my schooling. I was like, hey, you know what? After this, I think I'm going to go to chiropractic school. And being traditional MDs, old school traditional MDs, they were like, we're going to disown you, if you do that. So I thought, I told my current CI at the time, and he's like, have you ever heard of Stanley Parrish? And I was like, who's Stanley Parrish? And he put this APTA magazine in front of me with the ad with this picture in black and white in the top left corner. If you guys are old school, you probably remember this. Had all his courses, and at the time, he had just started a doctor of physical therapy program along with a manual therapy residency. So I did that. I asked my ortho professor to be a resident with him. I started literally the Monday after I graduated with my BS and MS. I entered this doctor of physical therapy program, and I started flying to St. Augustine to take all of Parrish's courses. Every other month or so, I was down in St. Augustine learning from Stanley Parrish and his faculty. So I graduated with that. I didn't pass my big exam the first time, and I remember I was devastated. It was the first major thing I ever failed as an overachiever. And my hero, my professor, said that I didn't pass the first time either. He's like, everyone passes, it may not be the first time. So I went back, passed that, and eventually became a manual therapy fellow. And at the time, early on in my career, I thought manual therapy is the end all be all. I'm fixing everyone with my magic hands and putting things back into place, breaking up scar tissue and fascia and all these things that I'm against now. And I took McKenzie just because I thought, hey, I should do this too. I want to learn from all the gurus. My goal was to become Highlander, there could be only one, not like I'm going to cut off all these gurus' heads and absorb their powers, but I'm going to learn from all the gurus. And then when they die off, I'm going to become the next guru. Because I was just my head just kept getting bigger and bigger and bigger. The more I learned, the more I added to my approach. And I just thought, I'm going to take all these courses. On day 1 of McKenzie A, I told my instructor, I'm only doing this for the credentials. I'm not even going to use it. And how arrogant that was, because it has become the cornerstone of my approach. Even though I've taken probably 60 plus manual therapy courses in addition to getting McKenzie certified, for me, it all comes back to McKenzie's principles of at least 80% of patients can self-treat. So, in addition to that, I've done all kinds of stuff outside of physical therapy, because in our search to help people who are what I call our non-responders, I've learned a lot about nutrition and breathing and mindfulness and all kinds of other things that should be in our wheelhouse, but typically are not. And I kind of, my goal is to help patients, but for me, it's, are you going to help the 10 or are you going to help the 10,000? Like, am I going to help 10 patients this week or am I going to help 10,000 patients this week? And my goal of helping 10,000 patients this week is not to have a mill clinic, but to teach as many physical therapists as possible that you can get great, rapid results by empowering patients with a self-treatment strategy. And then manual therapy is just this kind of spice on top that helps patients be more compliant because it helps them be, helps their recovery, what I call a recovery plan, what most people call home exercises, helps the recovery plan be as pain-free or as threat-free as possible. So that's me in a nutshell.
What a cool story. I mean, as you, and it's interesting. So I've only, I've been practicing probably, half the time that you've been, but I went through like a very similar journey in regards to like collecting all these various different tools, right? And I noticed for me that the more time that I spend in the clinic and helping people, I realized that, okay, maybe I have like 100 tools, 150 tools available to me, but for the most part, a large percentage of the patients that I work with, I only need maybe 5 to 10 tools, but then having those other options, but it's all really kind of based on, what the patient or the client is presenting in front of you. And I think this is actually what got us really engaged, or got our conversation engaged on LinkedIn, because I think you posted something about some specific modality, or there was a post about asking like a specific modality, whether it be a manipulation, everything like that. And I think I commented, I was like, this is all a great tool, but like this might be more like, if you look at the kitchen, this might be more like a lemon zester versus an actual chef's knife, the chef's knife that you end up using more often. And I realized that for the most part, the more experience I get, the more I can, like, tools I acquire, but then also realizing that you can have some big general tools. And then when you get down to the rabbit hole and the patients need something a little bit more specific, you can then provide it for them. So yeah, so very, very cool. So and here you are inspiring clinicians like me to be able to, help more people. And I love the aspect of self-treatment, because for the most part, one of the challenges in healthcare is oftentimes the power dynamic is very off, right? The provider kind of holds all the power. People go to the provider because it's like, you have all the answers. But recovery is an active process, right? Both patient and clinician need to be actively engaged. And it's not like you can't just go in and expect this person to just fix you without the necessary tool that you need to implement yourself. And so let's talk about the realm of sciatica pain, right? Because the majority of the patients who are coming in, the majority of the clients, people who are listening to this show are dealing with sciatica pain in one form or the other. So I know that, especially with like all the tools and the knowledge that you're teaching clinicians, I think one of the things that you do a particularly good job at is actually asking the right questions. And I think what's important is when you ask the right questions, you can get the necessary information to help you build up your hypothesis or assumption, which then kind of guides your treatment. So in the realm of sciatica pain, tell us a little bit more about some of the common questions. Like, if your patient comes into your office, right, and it's like, okay, you're going to take a range of motion exam and everything, but what are some of the key questions that helps you figure out what you're dealing with?
Yeah, I think, again, going back to Robin McKenzie, I think he was one of the first clinicians to really emphasize a good history. And I know that one of the knocks I've heard, probably clinicians who were more on the ignorant side of like, oh yeah, the first McKenzie course is like 4 days of learning to fill out a form. But that form has all the right questions. It's a standardized method of asking questions. And it was a quote that he said, like, if you ask the right questions, you're going to get a solution, something like that. That's one of his quotes, something similar. I'm paraphrasing it. But I think, again, asking people, I think PTs are pretty good about asking, well, what makes you worse, right? Oh, it's bending, it's sitting, it's a Valsalva, or like, bearing down, lifting something heavy, lifting up my child, golfing, whatever. But I'm not sure if other clinicians like Maitland and all these other gurus of our profession, I don't know if they ever asked what makes you better. And even if they did they build upon that? Because that's the key thing. Because for me, it's all about, I talk about this cup analogy. I get this from Greg Lehman, who's a great PT and chiropractor. But he talks about recovery as a cup. And if like your cup is this big and it starts off this full, the amount of like fluid that it takes to empty is like a buffer zone. That fluid is like representation of how long can you sit, how much can you lift, how long can you walk, how long can you stand on one leg, how deep can you squat. So it's like a buffer zone of activity and range and load of your joints, load of your muscles, load of your actual nervous system and stress and things like that. So anytime the cup overflows, and that's a result of potentially their physical injury, maybe even a disc issue, inflammation, all those things are not things that necessarily cause the cup to overflow immediately, unless it's a severe injury with major trauma. But like a disc issue might be a little bit of fluid. Some arthritis might be a little bit of fluid, right? Like a pinched nerve might be a little bit of fluid, but it's not something that causes it to overflow. So essentially, I think going back to what makes it better or makes it worse, we're trying to figure out what triggers the sciatica or what triggers the complaints. So what fills up the cup, and then also what empties the cup. Because for me, I would rather treat an 8 to 9 out of 10, so super severe pain with radiating leg pain that comes and goes, because that means that there are times when the nervous system or the brain is not detecting threat. That's when the cup overflows. There's a threat detection in the central nervous system or the brain, and there'll be an output of pain, and that's just a brain's doing its job. Great job protecting you. But if we can empty the cup faster than it fills up, then typically you recover, right? So it all goes back to patient's behaviors. Like, what are you doing that fills up the cup, and can you do an extremely high dosage of things that empty the cup? So if the pain is intermittent, even if it's severe, I know that there are times when your nervous system feels safe, so we can capitalize on that. Because again, going back to like, what would I rather treat? Sure, 8 to 9 out of 10 intermittent pain with leg pain, or 2 to 3 out of 10 true constant pain. Maybe they wake up every day with a cup that is mostly full, and plus their cup is extremely small because they've avoided movement due to what we call fear avoidance or anxiety of movement, fear of movement. They've avoided movement and activities for so long that now their buffer zone is so small, everything hurts. And the longer that goes on, the harder it is to treat. So even a mild, true constant pain is much harder in my book than that severe, intermittent, acute pain. What do you think?
This episode is brought to you by the Patient Advocate Program. Are you tired of not having support between your rehab sessions? Introducing the Patient Advocate Program, and we're focused on your recovery, and we're offering you 24/7 access to a doctorate of physical therapy. Stop waiting in line to be seen and stop spending hours doing long exercise programs. Imagine being able to get all of your care delivered straight to your phone. Best of all, it's affordable. We believe everyone deserves top-notch relief without breaking the bank. So why wait? Take control of your health today and visit ptpatientadvocate.com and book your free call with our experts. Yeah, I'm right there with you. I mean, this brings up the question, because oftentimes, and you probably come across this question a fair amount too, when patients see you in the clinic, they're like, well, how long is this going to take? How long is my recovery going to be? Is there hope for me to recover? And oftentimes, I'm going to pause right there, because I actually, like, the big premise of this show is to help people understand that we should be focusing on the activities that make us feel better. We should be either minimizing or modifying the activities that make us feel worse. So that way we can figure out, well, what's happening? Are we, filling our cup too much, and are we filling our cup too much because we don't have the capacity to handle it, or are we just moving in a way irresponsibly as well, right? So, but what I was about to say, like, oh yeah, when patients come and they're like, Ashley, how long is this going to take? This then brings up this concept of, prognostic indicators, like things that will actually point in the direction. It's like, okay, these are the things that are working in your favor. And one of the things, like with you saying that you would rather work with a patient who has 8 to 9 out of 10 pain that is intermittent, compared to someone who just experiences like a constant dull aspect as well, is I'm thinking for me, as a clinician, from a positive indicator, is that if we can find a pattern in regards to what is improving or changing this person's pain, that gives us a lot more information compared to, I literally feel this pain from the moment I open my eyes to the moment I close my eyes. Is there any other positive things that you notice that helps to say, okay, you were talking about the fast and slow responders. So let's talk about that too, because now obviously pain management is for sure a process, and there are some people who are going to respond very quickly. There are going to be some people who take a little bit longer. So what are those qualities that you look for or that you come across that helps you figure out the difference?
Sure. There's several things, what I call clinical practice patterns, that I teach, that if a patient fits these, like even if it's severe pain, if it's intermittent, for me, it's positive prognostic. If someone has moderate to severe limited mobility, but mostly in one plane. Like flexion might hurt, but they might be really limited in backward bending, or forward bending may hurt or be severely limited, but they're also more limited in backward bending, or like they might have a hip particularly, or an ankle on the sciatic side that is more limited than on the other side. Like if there's a big asymmetry in motion, but mostly in one plane, for me, that's a positive prognostication. If it's like 6 months in duration, but it's episodic and it comes and goes and comes and goes, because people think like, oh, I've had this pain for like 2 years, I had this pain for 8 months. Well, has it ever gone away? Oh yeah, sometimes it goes away for weeks, or it goes away for days, or it goes away for hours. For me, again, with intermittent pain, if it can even go away for hours, I also have this positive message because I'm a very glass half full kind of guy. If your pain go away from hours, we can turn those hours into days. Then if it go away for days, we can turn those days into weeks, and weeks can turn into months, and then it's just pretty much gone at that point. So how long is it going to take? I can't answer that, but there's one thing I think the physical therapist's best, or any rehab clinician in general, but PTs, I think for the most part, our biggest superpower is giving patients hope. So I think there's just too many naysayers out there, like, oh, you shouldn't deadlift anymore, you shouldn't run anymore because whatever, it causes your sciatica, it's going to blow out a disc. And you just tell people to give up the things that they love, but also things that are actually making them healthier, and all this rest and everything is actually going to make them, nothing's going to make you, wear out faster and get older faster than inactivity. So yeah, other good prognosticators, like if you have sciatic pain, but it's more of like along a line, that might be a little bit more difficult than if it's just diffuse kind of leg pain. But overall, if the leg pain kind of travels up and down versus it being constant, if you don't have neuroscience, meaning that you don't have foot drop, or you don't have loss of bowel and bladder control, or something that may indicate a major nerve root impingement, those tend to be more difficult cases. Pain below the knee, that might be a little bit more difficult, but not impossible, and especially with the tools that Mackenzie gave us, because again, until then, everyone was just like tractioning and unloading and avoiding activity, versus he was the first one to actually load these things up. Let's do things, get people back in weight bearing as fast as possible. And I think bang for buck, I don't really care how long someone has had pain, because I think what the research says is you do need to give people a realistic expectation that this might take a while. But anyone who has ever done Mackenzie well and seen the power of the Mackenzie method knows that I don't care how long people have had pain. Because they might be better in like the average good Mackenzie, they call it Mackenzie 6. The average good Mackenzie practitioner will get someone better in 6 visits or less. And I think it's like a disservice to tell people they might need 20 visits or something. So I mean, it might be very fast regardless of how long you've had pain, but it also depends on, do you fit those categories that kind of tell me that this is probably going to be an easier case regardless of how severe your pain is.
You bring up the Mackenzie method, and I think what it's a great way to treat. I think oftentimes the listeners and patients come across a clinician, therapist, whoever, and the oftentimes when they're speaking with me, they're like, oh, they gave me Mackenzie press-ups, and all they did was Mackenzie press-ups.
All it was press-ups, yeah.
Right. And I think, one, it was great the fact that, press-ups became a little bit more popularized, because I remember even when I was graduating from school, it was like, okay, you're having back pain and sciatica, and this patient is an office worker. And I remember I would give them the standard pelvic tilts, knee to chest, double knee to chest, forward bends. It was like all the things that would continue to fill up this patient's cup. And I was like, why isn't this patient getting any better? And then being able to literally take a step back and to be able to say, oh, well, maybe extension could be helpful. But then for me, I didn't say, okay, every patient is going to benefit from back extensions. It made me really look into, because Mackenzie is the systematic way to be able to look and treat a patient. And I think oftentimes patients will think, okay, well, the Mackenzie method didn't work for me because all I did was press ups. Can you clarify a little bit more for the listeners that it's not just press ups and that it's a way to, yeah.
Yeah. I mean, what it is that it's not just press ups, because that's like saying, the only thing you do when you go to the doctor is get antibiotics for everything, or you get anti-inflammatories for everything. There's no one thing that's going to solve all problems, right? But it's Mackenzie method. It's called a method because you ask this series of questions. You take a great history. You listen to the patient. You figure out what's making them worse, what fills up their cup, what empties their cup. And then you find what he called the directional preference. It might be extension, it might be bending, it might be twisting, it might be a variation on those things. It might be upright, it might have to be in lying if you can't handle upright or weight bearing positions. But 80% of low back pain patients and 80% of patients in general can learn how to self-treat if they have the right direction. And it is a very generic prescription just to give it only press-ups. Press-ups might be appropriate, but also, even if press-ups are appropriate, the other thing is that dosage, right? And I think you saw me probably comment us on LinkedIn too, because someone said movement is medicine. And I'm like, oh man, I love this as a saying. Physical therapists are always saying movement is medicine, but we don't prescribe it like medicine is the thing. The one thing MDs and anyone who prescribes medicine know is that medicine has to have a therapeutic dose. And someone might get press-ups, and press-ups might be the one major thing that's going to empty your cup, but they're like, yeah, do this 2 or 3 times a day. And it's super generic. And I loved Mackenzie's thing. His average prescription was like, do this 10 times an hour. When I say, hey, you do need to do this 10 times an hour, patients are always like, what do you mean 10 times an hour? I mean 10 times an hour, but I also mean enough to stay ahead of it. Like, if you avoid the things that fill up your cup, you might be able to get away with doing it like 4 or 5 times a day. And also if you, I don't correct posture anymore. I don't give Mackenzie lumbar rolls, but I tell people avoid prolonged sitting or any static position of over 20 to 30 minutes. Get up and drink so much water that you have to pee, because that's like you're apparently sitting in a good or bad position long enough to make you have raging leg pain, but you're not going to pee your own pants regardless of because that's just like more socially unacceptable. No one can see your sciatica, but you're not going to pee your pants, right? So that was actually a strategy that I developed for myself working for an insurance company when I ended up with sciatica, because I would always think like, I'm going to take one more case, I'm going to take one more phone call, I'm going to do one more approval or denial. 6 hours later, I have raging leg pain. I'm like, man, I can't even like follow my own advice. So I started drinking this huge bottle of water, like 20 ounces every hour, to make me get up. And then I would do a couple press ups or extensions or side glides or something like that to just prevent my cup from filling up and also empty it. So again, I think like the best news is that typically you can solve these problems if you have the right direction. And that's why it's important not necessarily just go on YouTube or watch like a generic Instagram video or just think that this one direction is going to help like 90% of pain, because in my experience, it's probably, especially if sciatica is like such a one-sided complaint, you probably need more of a one-sided solution at first to get that pain out of your leg. And then you can go with like the standard press-ups or extensions.
Yeah, that makes a ton of sense. And I appreciate you I appreciate you bringing up the concept of dosage, because I remember someone was like, oh, you got to do 30 of them every single hour. I was like, that seems like a lot. And especially if that person didn't necessarily have a directional preference into extension to begin with, that's probably going to end up filling their cup up more so than emptying it. And I really enjoy the cup analogy. And so oftentimes what I'll tell the clients that I work with who have issues tolerating sitting, we'll make some adjustments to their sitting. So then that way we can kind of, enlarge the cup a little bit, but 100%, I'll either say drink enough water so that you can pee. And luckily enough, a lot of the people who are listening now probably have access to some sort of standing desk. So I'll often say, spend an hour standing and spend an hour sitting. Gives you the opportunity to have a little bit more of that variety, which is very important. Variety in movement, but also dosage and movement as well.
Sure. I'm at a standing desk now. That's why I always go back and forth like this.
Yeah. And that's the beauty about standing desks is that, well, one, I'm assuming you probably have a much bigger workspace. And number two is that, you have the opportunity to move around. And this is one of my professional goals when I end up becoming like a, extremely old man is donating a set of standing desks to a school, like to the point where the kids, they have so much energy. And I remember it would be safe to assume that if I was given a standing desk when I was in school, I'd probably have a much better learning experience. And I remember even in physical therapy school, we were actually, our desks were the treatment plinths, which were all like a fixed height. So we were just like, here we are in physical therapy, working on trying to improve pain. Yet we're sitting in positions for 3 to 4 hours in the least ideal position. Now,
it's about learning. I just watched a YouTube video from a martial artist who was saying that like learning best takes place when you're in like this bell curve of like to the left is like everything is boring and not challenging, and to the right is everything is frustrating and not challenging, and like too challenging, so you kind of give it up. And the top of the bell curve where you get the most amount of learning is when play becomes like enjoyable, but it's still like somewhat challenging, and that's when I guess people learn the best. And I'm thinking like, man, and then we just tell kids like, you get recess once a day in the middle of the day, you should probably start off with that and prime them for learning, and then get up like every 20, 30 minutes. Like, why do they have to sit so long? It's crazy.
Yeah, it's unbelievable. So I think, if this is for listeners, this is us granting you permission to get up and move around.
The next position is the best, or the best position is the next position. There's not good or bad postures.
Yeah, there aren't good or bad postures. There could be a posture that you're in for just too long of a time, and it's just like, if you're watching this video, I'm double jointed, and I can actually like pull my forward finger back like this. And right now it doesn't hurt me, but if I hold this probably for an hour, it's probably going to get pretty achy. And so what I should be doing is releasing that and going back into a different motion. And I think that was actually one thing that you brought up. Well, one, in this conversation, you talked about, there's no good and bad posture. But I remember there was an article or a clip of you on another podcast talking about this concept of, well, the majority of us humans spend a lot of time in a flexed position. And if we stand up, it's like, okay, we're extremely stiff. Can you tell us a little bit more about that in regards to, I appreciate the analogies and the visualization of how this works.
Sure. I mean, the thing with our necks and our backs is, Mackenzie had these statistics that said the average person forward bends 2,000 to 3,000 times a day. And so our spines are not only designed to forward bend, they're designed to forward bend and backward bend. But since our hips are flexed and our spines are flexed and our head or neck are flexed, anytime you're actually not bending, you're pretty much in flexion the majority of the day. So I always say, like, if we treated our other joints like we treated our spines, how would they feel? So with our elbows, like, we also may bend our elbows thousands of times a day, but we walk around like this. We don't, we walk around with our elbows straight. We don't walk around with our elbows bent all the time. So just imagine if you bent your elbows thousands of times a day, but then when you're not actively moving them, you just keep them bent all day. So yeah, you sit or stand at your desk for like 5 or 6 hours when you're at work, and you get up, you're like, oh man, or you get out of a long car ride, and you don't actually touch your toes. Instinctively, you're actually kind of backward bend. So yeah, how would your elbows feel if you finally straighten them out at the end of the day? Be like, oh man, it's really stiff. But you do that to your spines day after day after day. And our spines are designed to flex and to extend. So the nervous system eventually starts to feel like extension is threatening. But if we just simply got up and moved around often, plus also went into extension regularly, I think a lot of this stuff could definitely be prevented.
Yeah. So variety is key. And that allows us to, one, from a physiological standpoint, improves circulation, improves like a neurological function. Looking at pain management specifically, sciatica pain. I think oftentimes people will come and they're like, Ashley, I've been working with this physical therapist for such a long period of time and things aren't working. And oftentimes one of the challenges is that people look at pain management as a binary thing. Do I have pain? Do I not have pain? And one thing that I'll share with them is I'll say, if we ever start working together, is I'll say, I like to say ground rules, but I'll say, here are the conditions, here are the expectations for of helping us understand, are we getting better or not? Because better is in fact better than looking at pain and no pain. So when it comes to looking for signs or symptoms or things that help you understand and help the clients understand that they are in fact making improvements, what are some of those things that people should be aware of? So then that way they can reevaluate their treatment plan and say, am I in fact getting better, or am I truly experiencing no improvement at all?
Right. Physical therapists often prescribe exercise in frequency, intensity, and duration. But when I take my history, I ask the same thing about their pain. Not only is it like 7 out of 10, oh yeah, it's going below my knee and my right leg, but how often are you getting it? Is it okay? So on day 1, 5 to 7 times a day. Each time you get it, it's maybe 20 to 30 minutes. So when they come back, and again, if you understand the concept that pain or sciatica or leg pain, radiating numbness, those kind of things, they're an output from the brain. Think of that as an alarm, right? Or volume in an alarm. Like if the volume goes up to 10. So people come back and they're like, hey, I did those exercises and I don't think I'm any better and I did them faithfully. And this is assuming that they avoided things that filled up the cup and they really dosed them as appropriate. And they're like, it's still a 7 out of 10. So then I can go back to, okay, well, how often are you getting it? Well, like once or twice a day. And how long do you have it once you get it? Well, now it's only like 1 or 2 minutes, or it's like 30 seconds. Okay, so for me, I'd be like, look, on day one, you said you had it 5 to 7 times a day and it was for 30 minutes or more. So we can't always change every single one of those variables. But I'm more excited again when intensity and when frequency and duration improve when intensity does not. Because I don't care if the volume of the alarm is the same. I know the patient does because it's like severe, especially if it's a 7 out of 10. But if it's happening less, what I tell patients, again, being a glass half full person, giving them hope, is if this happens all of a sudden only once or twice a day and then every other day, but every time it goes off, it's a 7, for whatever reason, your brain is just always signaling this is dangerous, this activity or this position or whatever is dangerous. We're not changing the volume, but we're definitely changing everything else about it. So if that, along with your function or your activities of daily living or your workouts or whatever, if all those things are improving, but you're still having pain, I think it's one of those things that you have to give permission. You have to give people permission to feel pain. You don't always have to be 0 out of 10 to be better. And I like what you're saying about better. Like, what's better? Is it getting back to the things you love and being also 100% better, or being able to do everything you love with having an alarm go off every once in a while? Because the alarm signals danger, but it doesn't mean damage. And that's the thing, right? So for me, it's all about measuring frequency, intensity, and duration. And I think you don't be focused on the intensity or the numerical rating or how bad it feels, but be more focused on how often does it happen and how quickly does it take you to recover from it.
I appreciate you going through that, and you're asking the folks more of these questions. And oftentimes when I get presented with that, I'll say, okay, tell me a little bit more about it. We are in a unique position where we can see people a little bit more regularly and then also have the time to ask those follow-up questions to get a better understanding. And I really do appreciate you saying, like, okay, well, when we first met, you were having these episodes, 5 to 7 times a day. Now it's down to 1 to 2. What ends up happening is I forgot, I've been focusing on this a lot recently, but it's this concept of what we call like bright spots or like wins, things that are actually like noticed that like something is positive. And so being able to experience less episodes, fantastic. And being able to celebrate on that. And I really appreciate also when you're saying like a lot of like the pain that you're feeling doesn't always necessarily mean damage, because I think it was you who coined the term thought viruses. Was that you? Or
I didn't coin it. No, David Butler did.
Butler did. Okay.
Yeah. Right. But I talk about it all the time.
Yeah. And it's like,
I don't even know if David Butler still does, but I still call them thought viruses.
Yeah, it's thought viruses. Pretty much, listeners, what thought virus is, and correct me if I'm wrong, Urson, but thought viruses is like you go to any practitioner and they're like saying, okay, this is damage and this is a cause of your pain and this is either going to get better or not going to get better. It already implants a seed of us thinking, okay, that's the issue. And we start to fixate on that. And then what ends up happening is because we fixate on it, it closes off our ability to get some of the insightful information from people like Dr. E and myself that can actually help you get better and experience less pain. Would you be able to care to elaborate on that, Dr. E?
Yeah, I mean, simply, we've known for well over 20 years. I mean, I mentioned David Butler. He was one of the pioneers, a physio from Australia, a manual therapist turned like pain science researcher, pain scientist, like the methodology and the research that physical therapists like Ashley and I use on our patients to basically give them hope and also tell them that things like disc herniations, facet arthropathy, pinched nerve, all these things that you may see that seem like terrible news on x-rays are actually very, very common. And again, one thing that David Butler calls them is like gray hairs on the inside. I think he meant that. I think he was or skin wrinkles on the inside. Like basically, what they started doing, again, more than 20 years ago, is x-raying, MRIing, CAT scanning people without pain and seeing what do their joints look like? What do their spines look like? What do the discs look like? And it turns out that a very high percentage of people with no symptoms whatsoever have positive findings, up to like 50 to 60% in the lumbar spine and up to 80% in the cervical spine have disc herniations, but they don't have any symptoms. So it's like, well, at what point are these common findings, and at what age? So the more another research, simple research that I like to ask people is like, based upon all this stuff that I've been telling you about discs being normal and arthritis being normal, and also your pain comes and goes, but if you say your pain is better in the morning and it's worse as the day goes on and it's better again in the evening, what happens when you x-ray yourself at those different points? Is it going to look better and worse and better? No, it's going to look exactly the same. Like the day before you had this onset of pain, if you MRI yourself, unless you had some kind of major trauma like a car accident, it would have looked just as bad or just as good. So going back to the research on MRIs, when they took two groups of people with let's just say we'll call it non-specific low back pain, because most like over 80% of low back pain doesn't have a specific cause. It doesn't mean that it's not severe. It just means we can't really trace a specific cause to it. And they gave them manual therapy and education and exercise was group one, and the second group was manual therapy, education, and exercise and MRI. And I asked my patients, well, which group do you think did better? And most of them say, based on what I've been teaching them and about how common these things are and about thought viruses, and how thought viruses are also something that can fill up your cup because it causes increased fear avoidance, increased kinesiophobia. They say like, oh yeah, the group with the MRI did worse. And it's true because it's just bad news. And I tell my patients who are kind of confused, it's that, well, imagine how you'd feel if a surgeon said, or a radiologist said like, oh, you have a major disc herniation and you need a fusion yesterday, which is like terrible. It's a terrible thought virus. You would feel worse. But if they said like, hey, you know what? I know your pain's really severe, but your MRI is completely negative. Those people are kind of like, what? Like whether it's positive or negative, you feel bad anyway. Because if it's negative, you're like, well, why do I have this pain? If it's positive, you're like, oh my gosh, I just need to live my life in a ball now and never go outside or do anything again. So yeah, I don't even know what your question was, but I just tend to ramble. Did I answer your question?
Oh, you did answer my question, which brings me up. I often like to say like MRIs do a fantastic job at spotting cancers and fractures. Like really, it's like if there's something truly sinister, like we use the MRI to make sure that you don't have a cancer in your spine, because that does happen in some cases. And us physical therapists, like we can't do anything if you have an actual tumor in your spine, right? And so if there's no tumor, the MRI did its job ultimately. So Dr. E, I know that you have to get yourself ready for your next patient. So this was awesome. I would love to, talk with you more. I'm really excited.
We'll do it again.
Yeah, we'll do it again. But for the listeners who are like, oh my gosh, Dr. E, I want to hear more. I want to learn more. I want to find out more information about everything. What's the best way to get in touch with you?
Well, I am at Modern Manual Therapy on Facebook, Instagram, and YouTube. If you just type in my name, you're probably not going to get my dad anymore. He's not that too prolific on social media. But yeah, I'm sure Ashley will include links to my stuff in my socials, and I do virtual visits. If for some reason Dr. Mack can't help you, maybe I could prod you along a little bit and then send you back. Yeah, if you have any questions, please reach out. I love answering people's questions and giving them hope.
Awesome. Dr. E, thank you so much for your time. And listeners, yeah, if you didn't get a chance to write down any of that, I'll put the information into the show notes. It's good seeing you, Dr. E.
All right. Hey, great to finally meet you, Ashley.
Thank you so much for tuning in. We hope you got some help from today's podcast. And for more info, check us out at ifixyoursciatica.com. Have a fantastic and pain-free day. No patient-therapist relationship is formed by listening to this podcast. We are not providing medical advice, and all information should be confirmed by a medical provider.